Hello students, good afternoon. I'm Dr. Michael Brennan and I'll be presenting on radiology and primary care. But before I do so, I'd like to just offer you a word of encouragement. I know many of you have families, some of you have small children, mostly all of you are working, and this can be a very stressful and difficult program to get through and made more difficult by the pandemic. So I want to just say, get through it. It's worth it. Do what you need to do for stress reduction and self-care. It's a great profession. Being a family nurse practitioner is awesome. I graduated in '92, so I've been doing this for close to 30 years. In my career, I've been able to work in primary care a lot, also emergency rooms, urgent care centers, clinical research, hospice. I'm a teacher for more than 5 years, and then I also have been able to go out in a mobile health unit to the farm worker camps here in upstate New York. I was previously a professor at UTEP. I currently am not. Because of COVID, moved up to Rochester, New York to be closer to family. So without further ado, I'm going to move myself off into the corner and say welcome to this beautiful campus virtually here that has the great Bhutanese architecture, which I think looks southwestern. This is from the airport. University of Texas at El Paso welcomes you. And these are my 4 children. From youngest to oldest, this is Liam. He's 22, Aaron is 24, Michaela is 26, and Connor is 28. And he's the one we're going to talk about because Connor, as a child, was not very coordinated. But he learned to ski, and in February at 2 a.m. on a Saturday night, he called us and said, I've got some good news and some bad news. Good news is I've skied my first black diamond trail, which are the most difficult, require expert skiers. Bad news is I broke my leg. And it wasn't just a simple tibia fracture as I thought it might be. It turned out to be this, which is a tibial plateau fracture. You'll see here the you'll see the break of the tibial plateau where it goes into the femoral condyle. Connor created enough force to just pound that femoral condyle down into the tibial plateau and shatter it, basically. So what do you do for that? This is what you do. Plate and screws by Dr. Nicholas, his surgeon in New York City, and put the bones back together. So that's called open reduction internal fixation, and you'll see the abbreviation ORIF quite commonly. There's Connor with his physical therapy apparatus, this machine that would flex and extend his knee passively and for hours so that he didn't lose his range of motion. The big take-home messages from today. We're going to talk about who, age, gender, risk factors, and presentation, what, which imaging study to order, where is going to be in the clinical setting, and when does the imaging need to be performed? Is this emergent or urgent? Why does it need to be performed? What's your clinical rationale? And always with an eye to cost effectiveness when ordering imaging, and use evidence-based practice management of findings once you do your imaging. At the conclusion of this lecture, you should be able to explain the historical development of imaging modalities, describe the advantages of different imaging studies, interpret common imaging results, common like chest X-ray, identify the appropriate imaging studies for a variety of chief complaints, practice cost effectiveness in ordering imaging studies, recognize when specialist referral can be preferable to imaging. And this is something I really want to drive home because there are times when a referral to a neurologist is the better way to go than ordering an MRI of the brain or lower back. Perform evidence-based follow-up to your imaging results, and then also review common interventional radiologic procedures is what we're going to do today. Friday, November 8th, 1895, that is Wilhelm on the right. Wilhelm Röntgens, a German physicist, was playing with electricity and cathode ray tubes and accidentally discovered X-rays. That is his wife. Her name is Anna Bertha. Not a very common name anymore. I haven't heard of a Bertha in a while, but that's her wedding ring on her hand that we see, and her bracelet down in this other photo. When Anna Bertha saw this picture of her bones, she said, "I have seen my death." That day, Friday, November 8th, is currently celebrated as the annual day of radiology. Chronology of diagnostic and interventional radiology. I'm going to move this down here, I think. The X-ray was discovered in 1895. Soon thereafter, the fluoroscopy came into being. Ultrasound was more than 60 years later. There was a gap there from 1896 to 1958, quite a long time. Endoscopy, 1960, Doppler ultrasounds in 66, mammography comes to the fore in 69, CTs in 71, and MRIs in 77. Excuse me, I've got a delay in advancing. I don't know what is causing that. Sorry, but let me go there. Excuse me for the technical difficulties. Chronology. Diagnostic and interventional radiology. In 77, you've got percutaneous angioplasty, then balloon expandable stents, which have saved so many lives. Spiral CT in 89, arterial embolization, that's often used for uterine fibroids. PET scans are developed in the year 2000, and then it was 2012 that we started to celebrate the annual day celebration of International Radiology. X-rays. They utilize electromagnetic radiation similar to visible light, but it's higher energy than light that can pass through the body, and then rays are absorbed according to the density of the tissue. So you can see here on this chest X-ray that air is transmitted and picked up as black. Soft tissues and bones are white, and the more white they are, the denser the material. So and this chest X-ray has a number of anatomical landmarks identified. So we're going to go over these a little bit more later, but you look at the well demarcated hemidiaphragms, the right and left. That's important. You're always going to want to look for that. You want to look for size of heart, and then the lung fields and the hilum for lymphadenopathy. This poor individual has severe rheumatoid arthritis. You can see the MCP joints can almost look like they're dislocated on both hands because it's so severe. So your radiological density is determined by the atomic number, which is the number of protons in an atom's nucleus, and calcium in bone has higher atomic numbers. So where there's more density, there's more of a white shadow, and X-rays are termed radiographs. I think we all know that. The ultrasound was developed in 58, as we said, and the probe is known as a transducer. And I love the technology of this, that the transducer is made of ceramic crystals called piezoelectrics, and they produce high frequency sound waves that then are reflected off structures in the body. And it is the echoes that generate the two-dimensional images of tissues and organs. Can be used anatomically or functionally. You can see the actual work of organs or the heart in an echocardiogram, and they can be used in a lot of areas in the body. CT scans, narrow beam X-ray technology, and just so you know, the opening to the CT scanner is called the gantry, and patients are slowly advanced through the gantry. I'm sure some of you have had a CT scan. and then the images are rotated around the body and then put back together for these images. And you can see here, the yellow arrow is extraluminal gas, the blue arrow is an appendicolith, and the red asterisk is stranding on the adjacent fat. So you can see all these things here in this X-ray. You're looking at the, sorry, not X-ray, CT scan, you're looking at the appendix. Here's a CT scan of the lungs on the left and the brain on the right. And you can see there's some abnormalities here in the brain. And the signals create these cross-sectional images that are then stacked together for what become 3D images. And they can be looked at from any angle. MRIs, another cool technology. Powerful magnets force the protons in the body to align with a strong magnetic field, and then they stimulate the protons to strain against the pull of the magnetic field. And then when the MRI magnets turn off, there's energy release from the protons as they realign with the magnetic field after the radio frequency current. So it's a cool technology to show us the inside of the body, particularly useful for soft tissues, and contrast agents can be used, and it does not use any damaging ionizing radiation at all. So the MRI is very safe. X-ray are useful for bones such as fractures and arthritis, lungs and heart, pneumonia, CHF, some tumors, foreign objects. The fluoroscopy is particularly useful for foreign objects when you're trying to retrieve them out of the body, which can be very difficult. I've pulled a lot of different things out of patients, including bullets and needles, and they can be hard to visualize. And then also for dental issues, you can pick up a dental abscess quite well on X-ray. Ultrasound has a number of different applications. One would be for an abnormal mammogram, and often on an order, if there's an abnormality picked up on the mammogram, they can go right to ultrasound. We all know about ultrasounds during pregnancy, but then some of the other structures that can be looked at are the heart, blood vessels, eyes, thyroid, brain, breast, abdominal organs, skin, bones, and muscles. So that's quite a range of applications, and the Dopplers are good for the carotid arteries and to rule out TVT. CT scan is particularly great for head injuries, especially if you're looking for hemorrhage or clots in the emergency room. Useful in the lungs for tumors, pulmonary emboli, fluid emphysema, pneumonia. Abdominal tumors can be picked up well on CT scan. They can be used on the heart, and then also for bones if you're looking for tumors or complex, if you're looking at complex fractures. MRI, state-of-the-art for soft tissue imaging, differentiate white and gray matter in the brain. You can use it well on the spinal cords and the nerves. This is where you're going to see your herniated disc, usually L4, L5. But MRIs are the best at imaging muscles, ligaments, and muscles, often used for the knee or a shoulder injury. You really get a clear view of what's going on, say in the shoulder, the girdle of the shoulder and the insertion of the tendons into the bone. Imaging tests used for screening. I left this slide blank for a moment to have you think about it. What screening tests utilize imaging? And one of the most common is going to be mammography for breast cancer, and this is the American Cancer Society recommendations. Women should get mammograms every year between the ages of 45 and 54. And then you can see on the left and right the other age group. Virtual colonoscopy for colon cancer. This is coming into vogue. People want this because they think it's going to be less uncomfortable. What's ironic about it is that you still need to do the same prep. And as anyone who's had a colonoscopy can tell you, the prep is the worst part. So it uses CT technology, and it's just used now for those who refuse the colonoscopy. You don't need sedation for it, but it does, like I said, have the same prep. And they need to use a small tube. The fill the colon and rectum with air. And if they find anything like polyps or suspicious areas, you're going to need a colonoscopy anyway. The virtual colonoscopy needs to be repeated every 5 years, while colonoscopy is every 10, which is why it has not replaced actual colonoscopy. Colonoscopy is still the gold standard for detecting colon cancer. Low-dose CT scan. This is new within the last, I'm going to say 5 years, that we have the low-dose CT scanners, and that they've been recommended for ruling out lung cancer. You'll see here that the primary group are 55 to 80-year-old smokers, or people that have quit within the last 15 years, or anyone that has smoked 30 pack years or more. Remember your calculation that if someone smokes 2 packs a day for 15 years, that's 30 pack years. Fetal ultrasound. This is done routinely. It's I can't think of a pregnancy that doesn't get a fetal ultrasound. So it's used to confirm the pregnancy and the location of the baby, determine the gestational age, which is more accurate in the first trimester than in later trimesters, actually. Number of fetuses, growth and development, evaluate the placenta and the amniotic fluid levels. You particularly want to rule out a low-lying placenta that could be a previa over the cervical os. You can identify birth defects early on, and you can figure out the presentation of the baby before delivery. My wife is a midwife. She is an expert at determining presentation. You can usually tell whether the baby is breech or not just by doing Leopold maneuvers and feeling the fetus. Cardiovascular disease screening. There are imaging tests used for this, such as the stress echo, the coronary artery calcium score, and then using ultrasound for carotid artery stenosis. But what I'm going to point out to you is that none of these tests are recommended as general screening measures by the U.S. Preventative Services Task Force, the U.S. PSTF, which you're going to want to become very familiar with. They are graded as I for insufficient evidence or D as discouraged. And I think particularly the coronary artery calcium score is discouraged. It hasn't come into common usage. So you can use an abdominal ultrasound for a AAA, and if you detect a AAA on ultrasound that's less than 5 centimeters, that will need to get serial ultrasounds, usually every year, for surveillance to make sure it's not growing and at risk of rupture. Here are the recommendations. I'm just going to point you to the top line here. The population is men ages 65 to 75 years who have ever smoked, and they get a one-time screening for the AAA, and that's for anyone who's ever smoked, and that's a grade B recommendation, so keep that in mind. The DEXA dual emission X-ray absorptiometry for osteoporosis, the recommendations are women 65 and older, including postmenopausal women younger than 65 who are at increased risk. Those would be the 2 categories of patients that you want to screen for osteoporosis. I'm going to suggest this app for you, and I'm going to ask you to do this right now, actually. Grab your phones, go to the App Store, and put in EPSS. It's the electronic version of the Preventative Services Task Force recommendations. And you can use this clinically all the time, because anytime you're doing a physical, you should know what screenings and immunizations are needed for your patients. And this is where you can get it all in one place. So load that up into your phones, and you'll find it very useful. Common fractures and dislocations. In the upper body, places that break and get dislocated would be the nasal bones, the clavicle, shoulders and elbows dislocate. A Collis fracture is of the distal radius. We're going to look at that more closely. Scaphoid bone is in your wrist, most common wrist bone to fracture. Boxer's fracture is the 5th metacarpal from punching someone or something. I actually see a boxer's fracture more from people getting angry and punching a wall than from punching another human being. Finger dislocation, very common in sports, as we'll see. And a comminuted distal phalanx is, comminuted means it's broken up into smaller pieces. So that's a common crush injury. What is this? What's your diagnosis? What part of the body are we looking at? There in the nares, this is the nose, that's the nasal septum, and this person has a nasal fracture. If they are well aligned, the treatment's pretty simple. It's going to take time in protecting the fracture. If it is displaced, I believe your local otolaryngologist will put 2 metal tubes up your nose and then shift the septum to one side or the other to bring it into proper alignment. What do we have here? There's a midshaft clavicle fracture, and you can see that the fragments are quite distant from one another. This is going to need some form of reduction or open reduction internal fixation. Those bones are not gonna knit together. This one is overriding. You can see the 2 ends of the fracture that are overriding each other, and often this will be left as is if it's not creating any functional abnormalities, because you'll see people with clavicle fractures that just have a large bump in the area of the clavicle from fractures like this that have not been realigned. This one has been. This is open reduction internal fixation of the distal third of the clavicle, which is unstable if not fixed through surgical means. What do we have here? Is this related to the clavicle, or am I changing topics? I am moving on to the shoulder. Any of you that have worked in emergency rooms or urgent care centers recognize this as a shoulder dislocation. To me, it looks anterior. Most common mechanism for someone who has loose ligaments in their shoulder girdle, throwing out the shoulder, dislocating it, would be driving a car, but needing to get something out of the back seat, reaching over the passenger seat into the back seat to grab something, because that is effectively abduction of the shoulder with external rotation and then extension. And those 3 things in combination will dislocate the shoulder. In the emergency room, we'll have someone walk their fingers up the front of their chest and up their face, and go up their forehead and up to the top of their head. And when they get to this level of abduction, internal rotation with shoulder extension, and abduction, the shoulder will pop back in. So that is how that does it. And I just made a mistake over shoulder flexion and extension, and I want to just review it with you so that you get this, that moving the shoulder, the arm forward is flexion, moving it back is extension. So as we do this, we are flexing, but then you get to the point of extension as you come over the top. Okay. Here we have that same shoulder dislocated anteriorly. This is the glenohumeral joint. This is the AC joint up at the top here. The acromion coming into the clavicle. And you'll see 2 problems with this. One is you'll get an impingement syndrome if those bones are too close and pressing on the rotator cuff. But you'll also can see an AC joint separation, which would be increasing the distance between these 2 bones. Oh, we got another story. This would be my family with a friend. This would be somebody who's looking really worried and concerned because he just slipped on black ice. This is in the Adirondack Mountains of New York. We're at 3,000 feet, and that's black ice. Some of you that live in the Southwest have probably never seen black ice, but that's very slippery. This guy slipped on the ice and basically wiped out his wife. He just took the legs right out from under her. Her left elbow came down on his hiking boot, causing an orthopedic injury that we're going to see soon. But here's all the paramedics and EMTs that quickly scampered up the mountain. Not so quickly, actually. It took hours. But the whole rescue team came up the mountain to get Catherine down the mountain, which took 5 hours from time of injury to getting down the mountain and into the ambulance to the hospital. And here you'll see on the right that the humerus is anteriorly dislocated from the elbow joint. And you'll see here on the bottom left that the reduction was successful. She got Versed so that she wouldn't remember it. And the way to reduce this was to put traction on the lower arm and then bend the elbow up to go back into place. It didn't require surgery, but for those 5 hours of coming down the mountain and ambulance ride, Catherine was in a lot of pain and got a lot of morphine. And boy, was I apologetic. So we're gonna do a quick video on nursemaid's elbow. This is a pediatrician reviewing how to reduce a nursemaid's elbow. And what I want you to focus on is the pediatrician more than her daughters who are trying to steal the show during this YouTube video, which I'm going to bring in here and make full screen. There we go. And it's only 4 minutes long, but she's gonna describe the mechanism of injury and the way to reduce a nursemaid's elbow, which is going to make all of you look very smart when this type of patient comes in to your office, and the child will not be using the arm; they'll be holding it close to themselves, and we may not get this. There we go. In the audio. I'm sorry, my computer is being slow. So I might forego this because I can teach this as well as she can. So let's just close that. Back to our screen. So if you look at me in the little picture, when a child gets pulled by the wrist, it's going to be either doing this activity you see where the mom's spinning the child by the wrist, or just holding a child's hand and walking with them, and a sudden jerking motion will separate the radial head from the lateral epicondyle where it inserts. And there's an annular ligament there on the elbow that will get wedged in between the radial head and the joint. So that's why the child can't move at the elbow, and it needs to be reduced. And the way to reduce it, I'm going to stand back a little bit. The child's holding the arm against their chest. And the way to reduce it is to give them a handshake with your other hand, and it would be palm to palm handshake. But you basically give them a handshake and you supinate their lower arm. So bring the palm up, and then you hold with one hand, you're holding the upper arm. With the other hand on their wrist, you're giving some traction. So your one hand is holding back here, the other hand is providing traction. And then while you're supinated and applying traction, you basically just flex the elbow, boom, and it'll pop back in. Again, that was a handshake to supinate, holding the upper arm, bring them forward, traction, and then flex the elbow. And the child will, the elbow will go back in, and the child will start moving around the room normally, and the parents will think you're a hero. Okay, and you do want to follow it up with an X-ray just to make sure there's not a bone chip from getting dislocated. Here we have a very common fracture. You should recognize these bones as the radius and the ulna. and this fracture is through the distal tip of the radius. This is called a Collis fracture, C-O-L-L-E-S. Fractures that happen a lot get named. The mechanism of injury here is falling on an outstretched hand. So we'll use the acronym F-O-O-H, FOO, falling on outstretched hand. So when you see that as the mechanism of injury, think Collis fracture first, because it is the most common. We're going to look at the carpal bones, because there's one of them in particular, the scaphoid, that we're going to spend more time with. But scaphoid, lunate, triquetrum, pisiform, trapezium, trapezoid, capitate, and hamate. I learned from the PAs, some of the first PAs, the physician assistants, were former corpsmen in Vietnam. And I worked with a group of them that were the first PAs in the country, and they taught me an off-color way to remember the organization of the carpal bones, and it's using the first letters. Some lovers try positions that they can't handle. So you can use that one, or a number of other acronyms to remember the order of the carpal bones. But the scaphoid is the one I want to focus in on here. So there is a scaphoid. That's the right scaphoid. You're looking posterior or anterior on a film. This is the thumb, and coming down to the scaphoid. And you can see the fracture here through the scaphoid. Scaphoid fractures are one of the #1 causes of malpractice lawsuits, because what happens is people fall on an outstretched hand, break the scaphoid, but because it doesn't become radiographically evident for 2 weeks, they don't get treated. And when they don't get treated, they get malunion or non-union of that bone because they've not been casted or had surgery, and then they lose some function of their wrist. So a word to the wise is treat any scaphoid injury as a fracture until proven otherwise, and you've got to wait. You have to immobilize the patient for 2 weeks so you can prove that it's broken or not broken. And the way to ascertain whether it might be broken is to check for anatomical snuff box tenderness. I'm going to bring my wrist up to the camera here. At the base of your thumb, you have 2 very prominent tendons. You've got the abductor hallucis brevis and the abductor hallucis longus, and these 2 tendons move the thumb. And in between those 2 tendons is a slight depression. Do this on yourselves, please, as I demonstrate. But feel the depression between your 2 tendons there, and what you're touching there is the scaphoid, the bone. So if someone falls on a hand or wrist and they have tenderness in the anatomical snuff box, you are immobilizing them in a position of function, which is like holding a can. This is a position of function. The wrist is not neutral for splinting and casting. It is extended a little bit because that is your position of function. All right, that's how you immobilize hands and fingers, with a little bit of function. You don't want to do full extension. Okay, so remember that, please. Scaphoid fractures. This is a boxer fracture. This is from punching the wall, and you can see the distal end of the 5th metacarpal is completely broken there. That's going to need open reduction internal fixation. I don't think that's not going to heal on its own. You've got too much deviation from being straight on that bone. That's too much angulation. So that's going to need, or if, open reduction internal fixation. The way you would treat this, if you get an X-ray and it's non-displaced, if it's just cracked through, is with an ulnar gutter splint, it's called, and that's a splint that goes down the ulnar aspect of the forearm, again with position of function of the hand, holding that hand. Okay. Ooh, this looks bad, huh? These athletes have all come undone with a dislocated finger. And these are very common in sports. Just people catch their finger on something, like down in the bottom here, he's catching his finger on second base. Or the football took out this right fifth finger. Dislocations are easy generally to reduce. They hurt when they're dislocated. Put some traction on that finger and just pull on it and move it to the middle of the joint, and it should pop back into place. But you'll have some ligamentous injury related to it. So that finger is going to need to be splinted again in position of function. Here's a comminuted distal phalanx fracture. You can see that it's in pieces. Often this happens with a crush injury, but you can also get a distal phalanx fracture from a tendon avulsing the bone. If you have a hyperextension of the distal phalanx, it can pull the bone right off with the pressure, the tension of the tendon. And those tendons are so important. The tendons that go out to the end of your finger, I'm going to use my index finger here. When you're examining someone with a hand injury, you want to check their MCP joint motion. You want to check their proximal interpharyngeal joint motion and their distal pharyngeal joint motion. You often have to stabilize the finger because they're going to bend at the end. You want to also flex at the proximal joint. So for the distal joint, you have to mobilize that proximal joint to get the DIP, distal interpharyngeal joint, to move. And you should know your FDP and your FDS. These two tendons, the FDS stands for flexor digitorum superficialis, and the FDP is flexor digitorum profundus, and Latin for the superficial tendon first, and then the profundus is underneath it. But then they switch places. You can see here in the middle of your screen where the FDP goes through the middle of the FDS to go out to the distal phalanx. But in your notes, when you have a hand injury, especially a laceration of the flexor surface, you're always going to want to document that FDS and FDP function are intact. And you got to check those tendons. Common fractures and dislocations of the lower body now. We're going to move on. The LS spine, pelvis fractures bleed a lot. You have to be very careful with that. Patients can die from hemorrhaging. Femoral neck fracture, those are common, the place for the femur to break. Patellar fractures fall directly on a knee. Osgood-Schlatter's, many of you would know of this. It's the outgrowth of the tibial tuberosity from increased tension from the patellar tendon, where it inserts in the lower leg at just below the knee joint. And what happens is the bones are growing faster than the muscles and tendons can adapt. So there's increased tension on that bone. If this is your femur coming down and this is the tibia, and you've got increased tension down at the tibial tuberosity, starts to cause micro fractures of the tibial tuberosity. The treatment for that is rest. You've got it. Usually it's middle schoolers and early high schoolers that have this problem, more in boys than in girls, just because they grow taller typically. So rest. You've got to take them out of basketball or soccer or whatever they're playing, and let those bones heal. Distal hip fractures are common. Navicular stress fractures, Jones fractures, we'll go over those. That's a fracture of the fifth metatarsal. Great toes break a lot because they stick out, and then the fifth toe gets dislocated or fractured because we catch it on things like the post of our bed after we get up to go to the bathroom at night. So pelvic fractures. I just want to drive home that mortality can happen with these because of the hemorrhaging. So you've got to be very careful if you're seeing someone with a pelvis fracture to make sure they're hemodynamically stable. Oh, I had a patient that had pelvis fractures in 2 different places, and she didn't bleed out, but she needed 90 screws and lots of plates to put her pelvis back together. This is an unfortunate story of my older sister, Mary Kay, who is 65. If you look at the top left, she was at a hotel that had a slippery surface that was wet. She slipped, femoral neck, well, not the neck. The neck is here where the arrow is. That's the neck. She broke her femur at the just distal to the femoral neck. They fixed her in your second slide across the top. They put a screw in with a rod down the middle of her femur and fixed the fracture. 8 months later, she is just walking when she feels sudden pain and shortening of her leg. And here you see that her open reduction internal fixation failed. The top of that rod actually broke right off. They needed to fix her again. They put a longer rod into her femur, and then this is the boondoggle of screws and plates and rods that went into her femoral head and neck and body. So she has a lot of hardware now, and it causes pain. The more hardware, the more discomfort people get. So if it's possible to take out hardware, it is recommended. I had a femoral neck fracture from playing hockey, and it's a long story, so I won't tell it. But a year after the surgery, the screws were backing out, and I couldn't sleep on my left side, so I had them remove the hardware. This is a horizontal beam of a knee joint, and what you should be able to see here is a patellar fracture. If you look at the fracture closely, you see this dark line coming from the top, and this person fell directly on their knee. This is what tibial tuberosity, Osgood-Schlatters disease can look like. So you have the patellar tendon coming down, inserting on that tibial tuberosity, and this tibial tuberosity is a mess. You can see that it's fractured and it's pulling off, and there's an overgrowth of bone because the tendon is just pulling so hard on the bone. The Ottawa ankle rules are an important means of determining whether someone who has sprained their ankle needs a fracture. So there's particular places where patients might experience pain, these darker areas. You want to palpate those directly, looking for a fracture. You're also going to base a lot on whether the patient was able to bear weight immediately after the injury and in the emergency department or urgent care center, wherever you're seeing them, maybe in the office. But if they have bone tenderness in those areas with inability to bear weight, both immediately and in your office, you've got to get a film. Okay. Here's a Jones fracture. This is a fracture of the 5th metatarsal. This happens with ankle sprains. If you roll your ankle, you do an inversion sprain where you supinate the foot, you can get a fracture of the 5th metatarsal. Most often this is going to need open reduction internal fixation with a screw. You can see in the bottom 2 pictures that patients have gotten long screws in through the joint to hold it stable. Here's a big toe fractures. The one on the left is a chip fracture. I had this from playing ultimate frisbee when I was 18. Had my girlfriend's brother, a podiatrist, remove the chip, and boy, did that help, because I had been walking around on it for a month just feeling the pain. These other fractures are, you can see preoperative and then postoperative, putting the pieces of the fracture back together with pins. Here's a bad 5th phalanx dislocation. That distal phalanx of the 5th toe is completely dislocated from the joint, and this can be easily reduced in the office. You might want to inject some lidocaine, but it's again traction with pulling the bone back into place. After doing so, you will want to buddy tape the toes, and you can see the purple ecchymosis on that 5th digit. And if you're able to pull it back in and pain is minimal, you can usually get away without an X-ray on these. But if there's any chance that you've got a bone fracture or chip, you should get a film. Reading chest X-rays, as easy as ABC. This is from my colleague Andrew Wolf, and we're just going to go through this fairly quickly because most often radiologists are going to be reading your chest X-rays for you. You're always going to want to compare to normal anatomy, to the patient's baseline if you can, and you need to consider the context in which you're viewing the film. Here are the bony structures. You can see the clavicles are in black on the right and left. The ribs are here with the red arrows. The humerus is the yellow arrow. Scapula is the green arrows here. Vertebrae, you can see the cervical and thoracic vertebrae up top. And then you'll notice the sternum in the middle has been wired back together after open heart surgery. Here are the diaphragmatic domes, all right? And notice the sharp angles, all right? That's what you want to see. You don't want any blurring down here, or you might have a pneumonia in your patient. Cardiac borders and aortic knob are visible here, and that looks like a normal heart size. The airways, you can see the trachea coming down, going into the main stem bronchi and the carina, and then down to the hilum. And this is where you'd get lymphadenopathy. Lateral film will show the aortic arch in red, the cardiac border in pink, diaphragmatic domes in green, and then your thoracic vertebrae in blue. And oftentimes, we'll be getting a chest X-ray to rule out pneumonia, but the radiologist will comment on degenerative joint disease in the thoracic spine. So your systematic approach is A, B, C, D, E, F, G, H, and I'm not going to read this to you. You can see what you're checking with each of the letters. But if you adopt a methodology, a systematic review like this, it'll make it so you don't overlook something. Okay, questions. And these links don't work because we're not live, but the questions are still be asked. Radiology for primary care. What is the most common cause for a chest X-ray to exhibit right and left clavicles of unequal sizes? You can see your answers A, B, C, and D. Take your best guess, but the answer is going to be A, positioning of patient during chest X-ray filming. It's going to be the most common reason that the clavicles will be unequal in size. What type of tissue appears black on a normal chest X-ray? We went over this a bit. Is the heart air-filled? Is going to be one of the questions I'm going to ask you. No, it's blood-filled, right? But air-filled will be areas like the trachea and the bronchi. Answer D. What type of tissue is going to appear white? Your correct answer here is B, bones like the clavicle and ribs. After verifying a patient's identity, which of the following did you do first when reading a chest X-ray? Well, there you have it. D got 100% of votes from a previous class. Verify the adequacy of light penetration. We're going to do some case studies now. Eduardo is a 48-year-old truck driver complaining of right elbow pain for the last 2 weeks. He denies any trauma. Pain is sharp, continuous, insidious in onset. He rates it as a 2 to 4 out of 10, and it is localized directly to the right epicondyle. I want you all to feel your right epicondyle. It's that bony bump on the lateral aspect of your elbow. And upon physical exam, resisted wrist extension. This maneuver, you try to get the patient to bring their wrist up against your hand, will cause the same exact pain. So that physical exam is pretty diagnostic. You suspect patient has right lateral epicondylitis. So your question is going to be, what imaging study are you going to order, right? Previously, 64% of students polled said get an X-ray. No one said ultrasound, bone scan, or MRI. But then 36% a third of students said none of the above. The students who said none of the above were correct. You do not need to x-ray lateral epicondylitis. You're not going to find much unless it's very advanced and there's micro fractures, but your treatment is going to be the same anyway. So in the setting of no trauma, this is an overuse injury, and rest is going to heal it. Actually, there's a number of things you can do, which I'm going to tell you quickly. That if someone has lateral epicondylitis, where it hurts right on the lateral epicondyle and it hurts with resisted extension in that same place, treatments are going to be rest, stop doing what's aggravating it. And I've seen this a lot in truck drivers because they're changing gears all the time. Actually, the garbage truck driver was who I remember most because they started to stop all the time. But rest, if you're playing tennis, stop for a period of time. If needed, you can immobilize with a sling. Usually not necessary, but I recommend patients use an ice cube massage on the lateral epicondyle, and you'll want to prescribe non-steroidal anti-inflammatory pain medications rather than Tylenol to decrease the inflammation. But really stopping the offending overuse is usually the biggest part of the cure. Dolores, muchos dolores. For those of you who don't speak Spanish, dolores would be pains, and this woman is going to have a lot of pains. Dolores is 62, who tripped on her front steps 1 hour ago, comes to your office complaining of bilateral wrist pains. She reports falling forward on her outstretched hands. Okay, remember that, FOOH. There was no head or neck injury or loss of consciousness, and her husband witnessed her tripping, which is important. Why? Why is it important that her husband witnessed her tripping? Because if he didn't, then you've got to think she had a stroke, she was hypotensive, she had syncope. You need to go through a lot of other differentials on why she might have fallen. This is a trip. She localizes her pains to the right distal radius. This is a bad pain. This is 8 out of 10. And her left wrist, 7 to 10. On the right distal radius, physical exam reveals 1 to 2 plus soft tissue swelling and point tenderness without bony deformity. That's the right distal radius. The left wrist shows full range of motion, no soft tissue swelling or deformity, but she is maximally tender in the anatomical stuff box. You should remember this from 10 minutes ago. And there's no elbow pain bilaterally. So what imaging will you order for Dolores? All right, are you going to x-ray her right wrist? Are you going to x-ray both of her wrists? Maybe get an ultrasound of the left wrist, or all of the above? Well, these students the majority were correct, and you're going to x-ray both wrists. Okay, she has a radiographically confirmed non-displaced fracture of her right distal radius. This is known as a Collis fracture. C, 100% of students scored on that. The x-ray of Dolores's left wrist is perfectly normal. Nothing shows up. Nonetheless, you suspect that she may have an occult scaphoid fracture, carpal tunnel syndrome, de Quervain's tenosynovitis, a Finkelstein's fracture, or none of the above. Okay, so you should remember this as well, that an occult scaphoid fracture is the most common malady that you should suspect. These other things would hurt in other areas. Carpal tunnel syndrome is going to be the numbness and tingling of your palm, wakes you up at night. Tapping on the carpal tunnel, which is canals, is going to cause pain in the palm. Not just pain, but neurogenic pain. It's going to be kind of a lightning bolt going out to the palm. And then you're also going to get the phalans. Inverted prayer sign is going to be positive for numbness and tingling in the palms. De Quervain's tenosynovitis is inflammation and irritation and pain of those two tendons on the thumb, the abductor hallucis brevis and longus, and the tendons themselves hurt, And the Finkelstein's test, it's not a Finkelstein's fracture. Finkelstein's test is going to involve putting your thumb inside your palm. So you bend the thumb down into your palm, wrap your fingers over that, and then ulnar deviation of the wrist. And this is, the provider's going to do this. You're going to stabilize the arm and then do ulnar deviation of the wrist. That's going to pull on these tendons at the base of the thumb. That is diagnostic for de Quervain's tenosynovitis. Usually can be remedied by a thumb spica splint when the splint holds the thumb up in some degree of extension. If that doesn't work, an orthopedist can inject the tendon sheath. In light of Dolores's injuries, you referred her to the Orthopedic Urgent Care Center at the hospital. Both wrists were casted, long arm cast on the right and a wrist only cast on the left. She calls you the following morning to say her right shoulder hurts. She describes the pain's location as right on the top of the shoulder at that bony lump. So what is that bony bump on the top of your shoulder? Remember from that X-ray I showed you earlier that is the acromion clavicular joint, the AC joint. So let's see what you think here. Cognizant of the mechanism of injury, she fell on outstretched hands, and the anatomical location of the pain, you suspect blank and order blank. Okay, the A, B, C, and D, try to read those quickly, but your correct answer is going to be C. An AC joint separation with right shoulder X-rays is what you're going to order. I have a quick funny story about this, that I developed a rotator cuff impingement syndrome in my AC joint because I played a lot of throwing sports like football and baseball, and they were talking about cutting off my distal clavicle to reduce the impingement in my shoulder. And I told you already, I broke my hip playing hockey. I tried to make a comeback 2 years later. I bought the best equipment going, and I was all excited. I was going to get back out there on the ice, and the first time I'm on the ice, I get going too fast, lose an edge, and I go slamming into the boards, and I separate my right shoulder AC joint, which hurt badly for a month. But my orthopedist gave me the bit of good news. He said, by separating your shoulder, you fixed your impingement syndrome. So I didn't need surgery any longer, and I've got great use of my shoulder. And I through trauma, fixed an impingement syndrome by separating the shoulder. So that can happen. Larry, a previously healthy 44-year-old teacher, presents to his PCP with severe low back pain for 2 days after moving some heavy boxes. He denies any precipitating trauma or history of low back pain. Pain is achy and sometimes sharp with movement, radiation of pain down the back of both legs to the knee. That's very important, both legs. Continent of both bowel and bladder. Why is that important? If someone has caught a Quinai syndrome, they will lose bowel and bladder function, and that is a medical emergency. So remember that, to always document that normal bowel and bladder function in someone with back pain. Denies any leg or foot weakness, demonstrable weakness in the distal lower leg, the foot and the big toe is also disconcerting for nerve impingement. Pain is worse with movement, including walking. What does that tell you? That tells you that rather than a fixed disc herniation, this could be the paraspinal muscles. Pain keeps me up at night, says Larry, and denies fever, chills, weight loss, or fatigue. Those are important because that tells you that he doesn't have an acute infection or that it's probably not cancer. So you always want to document these things. No relief from acetaminophen or ibuprofen. His previous medical history is significant for type 2 diabetes. His only medication is metformin 500 BID. He denies smoking or illicit drug use and occasionally drinks alcohol. Larry is overweight with a BMI of 32 and in moderate discomfort with normal gait, moderate tenderness bilaterally to palpation of lumbar paraspinous muscles, lumbar range of motion in all planes limited by his pain, distal strength and sensation are within normal limits, equal and symmetrical bilaterally, DTRs at knee or an ankle are 2+ and equal bilaterally, and the straight leg raising test is negative bilaterally. So that's when you patient's leg, they keep it in full neutral position, and you grab under their heel and lift up their leg off the exam table. And if they've got a herniated disc, they will experience back pain as you stretch the nerve. Okay, so he's got an abnormal exam, but it's mostly the tenderness in the paraspinal muscles. So given Larry's clinical presentation, everything you just heard, which evidence-based imaging of his LS spine would you order? Would you get an X-ray? Would you order an MRI, a CT scan, an ultrasound, or none of the above? So in a previous class, 21% of students had an X-ray. There was no trauma. So an X-ray is not going to show you anything but maybe some osteoporosis or disc space narrowing with osteoarthritis of the lumbar sacral spine, which given this picture, you don't need to go looking for that. An MRI can show you a disc herniation, but you don't need to pursue that at this time. Everyone with low back pain that doesn't have acute neurological symptoms can have a trial of conservative therapy. So the correct answer is none of the above. This is a dense slide, and I don't expect you to read this here and now, but this is the imaging algorithm up to date for acute low back pain. So if you follow this down from top to bottom, you'll see what imaging you might order when. I tend to not get MRIs of the lower back. In my mind, that's something you do to rule in or out the need for surgery. So I'm going to let the neurosurgeon make that determination. If someone fails conservative therapy, they have bad pain with some neurological findings 6 weeks out, then I'll refer to a neurosurgeon and let them manage the patient, including ordering the MRI, but then responding to the MRI. If I get an MRI and patients have some disc herniations, I cannot be absolutely certain that's not a false negative, or sorry, false positive, because most of us walking around have some level of disc herniation with no symptoms. So very careful. I don't know that I've ordered an MRI of a lumbar sacral spine in decades. And I'm very hesitant to order X-rays as well, except in the setting of trauma, because it's 30 times the radiation of a chest X-ray. Take a film of the lumbar sacral spine, and that's also an area where you have your gonads and you don't want to be radiating them if you've got someone of childbearing age. Low back pain. We want to talk about the red flags of symptoms and clinical presentation. I've kind of mentioned this, but lots of bowel or bladder function or saddle anesthesia would be bad signs that for possible Cauda-Equini syndrome, focal neurosensory or neuromotor deficits, trauma or osteoporosis or chronic glucocorticoid use, age greater than 70, suspicion of cancer or fever or infection, and unrelenting severe pain. These would be red flags that you need to do something more than you're doing. So Carla is a 40-year-old female, presents with intermittent right upper quadrant pain that is described as stabbing and crampy that radiates to her back for the last 2 weeks. No pain or fever currently, but has noted pain was worst after eating pizza, high in fat and saturated fat. She's gravid 2, para 2. She's fertile. She's got a BMI of 36, comfortable. Abdominal exam reveals positive Murphy sign. Murphy sign is when you press into I might stand up on a chair. You can see me in the little picture. Gallbladder is on the right side, and it's more towards the midline. So when you're going to palpate for the liver on the lateral aspect of the right side, you're going to do a Murphy sign by pressing in. It's hard for me to angle this. I got to do it this way, but you normally do it with palm down. But you go in deep and ask the patient to take a deep inhalation. And if there's respiratory arrest, not that they stop breathing for a long period of time, but in the moment, if they can't take a deep breath, that's a positive Murphy sign, which is consistent with cholecystitis. So You suspect Carla is having gallstone attacks or biliary colic, and you order, well, this one seems like it's easy. You don't get X-ray, CT scan, or MRI, you get an ultrasound. Imaging for anatomical areas. I wanted to go over this quickly. That for the brain, CT and MRI, sinuses, X-ray followed by CT as needed, C-spine, CT or MRI, well, films, plain films as well, for in the setting of trauma. But if you think it's neurological, you're going to want to get the MRI. Thyroid gland is most commonly imaged with ultrasound. Lungs, most often chest X-ray, but of course CT and MRI can also be used. The heart is most often imaged with ultrasound, with a stress echo, abdomen ultrasound, or sometimes spiral CT. You can also get an abdominal flat plate to look for free air. Bones are going to be X-rays. Soft tissue is going to be better with an MRI. So just keeping those categories in your mind. Interventional radiology has come a long way. Now just the things that can be done are life-saving. The angioplasty and stenting can extend someone's life significantly who has atherosclerotic cardiovascular disease. IVC filters for DVT with risk of pulmonary embolus. I had a patient with this yesterday. Young guy, 18-year-old, got a DVT in his iliac vein and ended up with an IVC filter, and he's on Xarelto 20 milligrams long-term. And his left calf is still 8 inches larger in diameter than his right calf. Embolization, I mentioned earlier, this is now done with, I think most commonly with fibroid tumors. They can embolize the arteries leading to the tumors and they shrivel up. Varicose vein ablation is something that's done quite commonly. Biopsies and fine needle aspirations of various parts of the body are done by interventional radiologists. And then also joint and bursa injections, not so much done by radiologists, but orthopedists will use fluoroscopy and real-time ultrasound to guide some of these injections. Find the fracture. Well, this is easy because you've got circles around the fracture, and this is all the same fracture. What are you going to call this? Is this a Jones fracture, a Boxer's fracture? No, this is a Collis fracture, distal radius. What's this one? Try to find the fracture here. This patient just, I think the mechanism of injury was hyperextending their foot. You can see a small ditzel over the navicular bone, and that is, I don't know if you can see my cursor, but small fragment. This is an avulsion fracture of the navicular. I guess you could have found it by reading the text off to the right as well. Make the diagnosis on this one. This is a knee. Patient is 74 years old, is complaining of chronic achy knee pain. And what you see here is almost a complete obliteration of the joint space. There is no cartilage left on the end of these bones. This is bone-to-bone osteoarthritis. This patient will likely need a knee replacement. Okay, so I hope you have enjoyed my lecture, and if we were in real time, I could entertain some questions, but please ask your faculty if you have further questions about this presentation on radiology and primary care. I'm simply going to end by wishing all of you great success in your nurse practitioner training and in your careers, which are going to commence soon. So remember, treat your patients as you would like to be treated, and there's always the place for empathy, compassion, and love in the exam room. I find caregivers that actually care for and love their patients a little bit do practice better medicine. Remember this reassuring quote, that more mistakes are made in medicine by those who do not care than by those who do not know. So you don't have to know everything, but you have to care enough to go look it up and figure it out on behalf of your patients. So all the best to all of you. Stay safe and enjoy your nurse practitioner careers. Thank you. I think it's still